Good morning. Today I will be presenting on our findings from the TDF2 open label extension in Botswana. And to begin, I'd like to start off with a bit of background. So the TDF2 study was a predecessor for the open label extension and was a randomized, double-blind, placebo-controlled clinical trial that enrolled 1,218 HIV-negative heterosexual young adults in Botswana. Participants were randomized to a once-daily combination pill containing tenofovir and emtricitabine or a placebo. Since 62% protective efficacy was demonstrated in TDF2, we provided open-label drug to TDF2 participants for 12 months in order to continue to assess safety, effectiveness, behavior risk compensation, and adherence to PrEP. So OLE screening started in February 2013 and ended in May 2013. After eligibility was determined and participants started drug, they attended monthly follow-up visits. At each visit, participants were dispensed a 30-day supply of drug and adherence counseling was provided. Dual rapid HIV testing was conducted with an antigen-antibody combination test, pregnancy test was performed, and condoms were dispensed. Quarterly visits included additional HIV testing with an antigen-antibody combo ELISA with safety labs. Risk reduction counseling was performed as well. Our retention strategies during the study included SMS text messaging and phone calls to remind our participants about their appointments. No reimbursement was provided at any point in order to simulate more of a real-world setting. After the study was complete, we measured tenofovir levels using dried blood spots, which were collected monthly. We selected 120 participants, which was roughly 52% of our population, and classified them to 4 groups with different time points in order to create a longitudinal view of adherence over the length of the study. This table shows the study month grouping. Groups 1, 2, and 3 contain participants who attended study visits throughout the length of the study. For Group 4, we selected participants who had missed 1 or more missed visits and tested blood spots around the time of those missed visits. So now moving into our findings. Of the former 1,218 TDF2 participants, 27% returned from the clinics and attended screening. This was experienced because Botswana has a highly mobile population and up to 4 years had elapsed between many participants' exits from TDF2 and recruitment into OLE. We found that many former participants' contact information was no longer current, but we ran newspaper and radio ads to attempt to address this issue. Once participants returned and were assessed for eligibility, 86% of those identified as eligible to start TDF-FTC. 33% did not complete follow-up, and the majority of study participants reported the reason as being due to work commitments. We suspect that the monthly study visits contributed to a decreased study visit adherence since approximately a half of a day was taken away from a work day each month to come to the clinic. Given this attrition experience, we looked at factors that could be associated with not completing the study. So in a univariate analysis, we looked at the baseline characteristics except for adverse events, which were defined as definitely or possibly related AEs experienced at any point during the length of the study. We saw that gender and adverse events were associated with not completing OLE. Females were 60% more likely than males to not complete the study. If participants did not experience an AE, then they were 2 times more likely to complete the study than those who did experience an AE. It's possible that this observed difference could be related to the more intensive follow-up efforts aimed at ensuring participant safety among those with an AE. The factors listed below were not associated with completing OLE, but were explored in these univariate models. The next couple of slides are going to look at the behavioral risk reported by participants over the course of the study. So for the following 2 models, we used a Poisson regression and counted for repeated measures within each subject. The graph shows the mean number of sex partners reported in the past 30 days over the length of the study by gender. We observed that the number of sex partners decreased by approximately 12% during the study, and males reported approximately 18% more sex partners in the past 30 days than females. This graph shows the mean number of condomless sex acts reported in the past 30 days over time. The overall number of condomless sex acts decreased by approximately 39% over the course of the study. There was no significance in this trend between males and females. And our next slides explore drug adherence using drug levels and self-reported adherence. So as discussed in the methods, we sampled 120 participants at various time points in the study. So using these dry blood spots collected at monthly visits, we measured the extracellular tenofovir levels. We found that overall, participants had detectable tenofovir at approximately 93% of the visits. And looking at detectability by gender, 87% of women had detectable drug over time, and 96% of men had detectable drug over time as well. In a multivariable model accounting for repeated measures for each time point, women were less likely to have detectable drug compared to men. In addition, participants in Gaborone were slightly more likely to have detectable drug than those in Francistown. Reported condomless sex acts and number of partners were not associated with drug detectability in this model. And next, we looked at drug detectability compared to the participants' 3-day self-report. We observed an association between 3-day self-reported adherence and drug detectability. At least 85% detectability was observed when at least one dose was reported in the last 3 days. Among those who reported taking no doses in the last 3 days, 60% had detectable drug. And now looking at the entire population of OLE participants, this slide shows that the self-reported adherence and overall 87% of participants reported taking the drug daily over the past 3 days. And finally, we observed no HIV infections among participants after initiation of TDF-FTC. Based on the incidents experienced during the TDF2 clinical trial reported in the methods, we would have expected 5 to 6 cases of HIV infection to occur in OLE. And so in conclusion, we observed high adherence to daily PrEP among both heterosexual men and women at risk for HIV. This study supports the recent findings that men and women who are at risk for HIV can adhere to daily PrEP. Also consistent with other recent studies, we observed a slight decrease in the number of sex partners and condomless sex acts during the course of the study. And so given that we observed no HIV infections, PrEP is a highly effective HIV prevention strategy when taken consistently. One potential consideration in the interpretation of these findings is that the TDF2 OLE study population participated in a previous clinical trial where they were given adherence and risk reduction counseling, which could have affected their responses and behavior during the OLE. Since this represents a self-selected, highly motivated population, our findings may not be representative of the general population. And we have not yet completed all of the drug level testing for all of our study participants. But our next steps include performing intracellular drug level testing using dried blood spots to give us a better look at the consistency of adherence over time. Additional steps include an analysis of a qualitative sub-study that was conducted toward the end of OLE that will help us to understand barriers and facilitators of adherence and visit adherence. And we will also look at the differences occurring in adherence between men and women. I'd like to acknowledge these individuals and institutions on this slide for their support and contributions to the TDF2 open label study. Thank you, or as we say in Botswana, kia loboha.